Good morning, everyone. Welcome to your March Public Employees Benefits Board meeting. Board members, if you would come on camera or let me know that you are here in some other way, that would be great. Hello. It is 9:35. My name is Dawn Mautner. She, her, and Aya are my pronouns, and I welcome you to your March PEB meeting. It's a turbulent time, and I look forward to seeing how PEB can serve our members and our communities in our work to provide stable and strong benefits for the families of our members. And I'm calling this meeting to order. Let's go ahead and do a roll call. Siobhan Martin, Vice Chair, are you with us this morning, please?
Good morning, I'm here.
Thank you. Greg Clauser, are you with us?
I am here.
Good morning, Greg. Chika Flowers, are you with us? We'll give Chicky another minute. Andrea Fultz, are you with us?
I'm present.
Thank you, Andy. Kimberly Hendricks.
I'm here. Good morning.
Good morning. Sean Parkman.
I'm here. Good morning.
Good morning, Sean. Emily Wong.
I'm here. Good morning.
Glad to hear it. Thanks, Emily. Good morning. Rep Rob Nose, are you with us this morning? Not hearing from Rep Nose and Cheeky Flowers. Are you with us?
Don, Chicky will be about 30 minutes late. This is Ollie.
Thanks, Ellie.
Bet.
Okay, but we have quorum and we are able to proceed with board business. Board members, have you had a chance to review the minutes?
This is Siobhan. I've reviewed the minutes and I would make a motion that we approve them as written.
Thanks, Siobhan.
This is Greg. I can second that. Greg Clover.
Thank you, Greg. If board members, if you approve the minutes as written, please say aye.
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 Thank you. Any opposed? None opposed, and the minutes are approved as written. Thank you. Let's go ahead to our next item on the agenda. We are going to discuss, as I believe we were made aware last month, the renewal for the Canopy partners. And there will be an action associated with this. So I look forward to hearing from our Mercer partners. Andrew, are you ready?
I am here and I am ready. Good morning, Dawn.
Good morning, Andrew. The floor is yours.
Right, great. And good morning, board members. As Dawn mentioned, we are going to start off with the Canopy EAP renewal before we transition into the rest of the agenda, which is largely focused on the round 2 broader renewal for the entire benefits program. As a reminder, this program for Canopy does renew July 1st of 2025, which is why we will be asking for a board vote at the conclusion of this section of the presentation. And so what we've tried to do here is to provide a little bit more background than what you saw last month with regards to not only what's included under Canopy, but also how the program has been performing to help you be a little bit better informed and feel comfortable on voting on this renewal. And so with that said, I'm going to hand it off to my colleague, Christy Ewing, who's going to lead us through these next couple of slides on Canopy. Christy, are you on?
I am here. Thanks, Andrew.
Great.
Hello, board members. So yes, as Andrew said, just wanting to provide you some updated information as far as services that Canopy offers, as well as some recent utilization and some benchmarking we'll look at today. So I think you've seen this slide before, but just sharing what the Canopy Employee Assistance Program offers. As many of you know, it's an individual services program that has therapy and coaching, that 24/7 crisis counseling telephonic line. They also have peer support through a partnership, and then they have digital cognitive behavioral therapy services. In addition to these individual services, EAPs also offer work-life services, which you can see here on the right. Again, really those all-encompassing services that help people navigate, day-to-day stressors and needs within their lives. And so then the other component that an EAP offers is their organizational services. And so Canopy does also offer to all of the agencies critical incident response, which is really, at the time of any type of disruptive event that might happen in the workplace, they can have a licensed counselor come out and facilitate either group sessions or be available for one-on-one sessions to help people as they're processing that disruptive event.
Skin is horrible and failed my finger.
As a reminder, if you're not our speaker, please do mute yourself. Thank you. Sorry, Christy. Oh, was that Christy? Hold on. Go ahead, please. Christy, that might have been me. One moment, please. Rose, can you help me? I think I disabled somebody's mic and it might have been Christy's.
Okay, hold on.
Thank you. It won't let me re-enable it.
Won't let me either. I think she has to do it somehow.
My apologies.
Oh, I got a message that says I'm no longer muted.
Yes.
Okay,
we can
you're
hear
not.
Oh, good. Okay.
Sorry
Thank
about
you.
that.
Thank you. That's okay. No worries. Okay, and so then those organizational services, the last thing there are manager consultations, so that managers can reach out to the EAP and get some guidance if they need some support in managing kind of an employee or something that might be happening within the workplace. So if we move to the next slide, we wanted to provide you just some current benchmarking. This is from our Mercer Health and Benefits survey that basically is just showing what we're seeing within the EAP market. And so a couple of key things here to point out is that we are seeing employers extending the number of sessions. You can see about 50% within this employer size, which is greater than 5,000, that about 50% of them have extended sessions of 8 or more. We're also seeing some additional care options. And for these two top things, I'd also just wanted to share, for the agencies within PEBB, there are a variable session model available. There's 3, 5, 6, and 8. And so, one of the key points here is that only about 14 of the 99 total PEBB agencies have selected that 8-session model. And I believe there's about 33 agencies that are on a 3-session model. Again, those care options, you all do have coaching available, which is an expanded modality. And then also for in-person, we are seeing an increase just across our book of business as far as in-person counseling at one or more work sites. Currently, PEBB doesn't have this at any of the agencies, but you do have, again, that ability for that critical incident response for somebody to come on site if there's a disruptive event. And then in other enhanced services, you do have through Canopy the peer support and the digital cognitive behavioral therapy. So in some areas, very aligned with national benchmarking. The one area that really, I think, has opportunity for improvement is in the number of sessions being offered. And that is also an area we saw as feedback. I think if we go to the next slide, we wanted to provide some information this is from the 2023 Vendor Partner Survey. And you can see here that, I'll try to orient you, the blue and the green are representative of satisfied and very satisfied. Then the purple and the pink are dissatisfied, very dissatisfied, and then kind of that green teal, which is the bar all the way to the right, and each of these is just a not applicable. And so we can really see here that the feedback and member satisfaction, the satisfied and very satisfied in these categories is relatively high. We did a little bit deeper dive with some of the feedback that was received from PEBB members in the dissatisfied and very dissatisfied areas. And a couple things this did relate to, it was the number of sessions available. There were a couple feedback for sure of that the 3 sessions was just not enough. And then also wanting to make sure that if there is the 3-session model, that if somebody's placed with a therapist, that therapist is also in network with the medical plan, so they can have that congruent kind of transition of care to when it switches within the medical and they don't have to change therapists. So that was definitely, and then one of the other feedback was a little bit of just wait times and getting in to see a provider. Again, this was back in 2023. Where we did see longer wait times for sure with providers. But overall, good, I think member satisfaction in each of these areas. If we move to the next slide. So just to give you a snapshot of some utilization currently with Canopy. So on this left-hand side, these are the individual EAP services, and this really is including everything that is offered as far as individual services. And so you can see, some increase in areas from 2023 to 2024. Also, that annualized utilization, hovering around that 7 to 8%. Which is a good utilization for an employee assistance program. As we move to the right, some individual utilization, also it shows you those on-site attendees, so that is either for a training or workshop, a critical incident event, and then also the consultations are on that right-hand side, so you can see kind of those management consultations. One thing I wanted to point out here at the bottom on the right-hand side is just the clinical services utilization. So when we look at EAP utilization, a lot of different EAP vendors show utilization in different ways. So we always like to kind of tease out what the clinical services utilization is. And you can see here, this is a good percentage. So 4 to 5% of clinical usage is good utilization, and oftentimes is indicative of members, being able to engage with counseling and enjoying the service and getting their needs met. Any questions on current utilization? All right, we can move to the next slide. All right, so this one's showing you the top 2 graphs are actually for all services for individuals. What the presenting problem here is. One thing about EAP is they're not diagnosing, so you're not necessarily going to see, they're not having a CPT code or anything like that, so there's not always the diagnosis. But there are, obviously when people call in, finding out exactly what is the presenting problem. So very similar from 2023 to 2024, where the top presenting problem is marriage and relationships, followed by anxiety, family circumstances or family needs, and then depression and stress management. And these are what we're seeing also within the medical plans as far as, the clinical needs, anxiety, depression, and stress. At the bottom is the peer support program. This has a new vendor that was launched June 1st of 2024. The vendor that is now partnered with Canopy is called Togetherall. Part of the change that was made was also now Togetherall does have some moderation and clinical oversight for the peer support program. It's all still very confidential, anonymous, but just if there's a high risk language or something being used, then there is a clinical moderation so that somebody can reach out to that person and connect them with the higher level of care that they might need. The peer support program is one area that we have lots of opportunity for higher engagement. And this is an area that Canopy has agreed to work with PEBB on a more robust kind of communication strategy, making sure that the peer support program is kind of front and center on the website so people know that service is available and makes it easy for people to engage. But again, they're typical. You can see here that the unique members who engaged is just about 66, so it's about 0.11%. Across Canopy's book of business, it is less than 1% as far as engagement. And as we start talking about the renewal, you'll see a commitment from Canopy to help increase that utilization. All right, so if we move to the next slide. Okay, so this side to orient you, at the top box here under current PEPM fees, we have it broken up for that EAP core services, and then the peer support is additional. And you can see again those three, we have the 3-session, 5-session, 6-session, and 8-session. The way that the EAP works as well is that it's counseling and coaching. So depending on somebody's clinical need, they can either match with a counselor or get support from a coach. And also these session models are based on the life event. So with an EAP, like for example, if somebody goes through a divorce in February and they want to engage with a counselor, they have their 3 sessions. And then in November, if they're feeling stressed from work and they want to engage either with a counselor or coach to help learn skills and resources to manage stress, then they would have that session model as well for that life event. One of the things you might notice here is that there's a difference in pricing, and it doesn't totally align with the session. So, the jump from 3 to 5 is different than the jump from 5 to 6 and vice, and then going on to the 8. So when we were talking about the renewal with Canopy, we kind of had 2 key things that we were looking to do. One was a slight nudge to those agencies that have the 3 counseling sessions, knowing that that's below benchmark, and we've had member feedback that 3 sessions does not meet their needs. So a little nudge in the pricing there to maybe make the higher session models, like a 5-session model, be of more value to an agency, but hopefully without a huge impact financially. So keeping that in mind. And then also wanting to maybe offer up a little bit more of a nudge as far as the difference between the prices of the different session models. So you can see some adjustments here for that as well. So agencies would still have the choice of which session model that they want. And this would be their renewals for the July 1st, 2025 contract. The last thing I wanted to point out is just with the peer support program here on the bottom table in the renewal PEPM fees, you can see that year 1, they've lowered that cost of the peer support program, again, to give some recognition, obviously, that the utilization of that program is low, and then working really hard in the year 1 to increase utilization in the peer support. if utilization increases to greater than 200 members, then in that year 2, the peer support cost would go up to 20 cents PEPM versus the 14. Any questions about renewal?
Christy, I
Rates or
don't have a
clarification?
question. I don't have a question. I just have a comment because we had the presentation in the last meeting around from our wellness folks in the PMAC and just the overall survey of what our members are needing. And I know finances was something added in that people are really seeking support around that, and the EAP does offer that. And my understanding is we only have one entity, OSU, is that correct, that doesn't use Canopy, and every other agency and higher ed institution does. And they choose the number of sessions. So we're really in the position of offering this to the agencies and higher ed and encouraging them to utilize it for their folks. I just want to double check on that, and maybe Ollie can respond on that.
Yeah, OSU is the only agency entity that I'm aware of, Siobhan, that kind of procures their own EAP.
So we're just making the decision here to say, hey, agencies and higher ed, you can take advantage of all these different services that our PEB members have said they want to be able to access. And just like Emily said in the chat, I also appreciate digging in that some of the dissatisfaction has been around not having more sessions. That is helpful to know.
So can I'm not, oh, go ahead, Sean.
No, go ahead.
Oh, I just wanted to know, so sorry, I'm sick at the moment, so my brain's not quite working. When you're saying like the $2, the 206, is that per member?
Yes, that is a PEPM. Yeah, so per employee per month.
Okay. Thank you.
Yeah, you're welcome.
Sean?
Yeah, so I'm understanding from the presentation that it looks like the peer support component is underutilized, and another way to say that is that we're overpaying for it. Like we're not getting the full value of what we're paying for that. And so I also heard you say that that there's discussion as part of the renewal about how to increase the peer support. And I would be interested in understanding more of those details. In my mind, like, changing around a few things on a website's not really going to significantly change the outcome of that. I would be more interested in what is the current referral system for peer support. What's that look like? And just kind of understanding some of the nuance about what exactly, well, not exactly, but a little more detail about what are we paying for when it comes to peer support? What kind of structure, what kind of support, and so on, and just kind of so that we can better understand what that really looks like. And then, so that's not a question to be dealt with right this minute. I'm just saying it's as we're moving through negotiations, that's something I'd be interested in understanding more about. And then the other item that I'm about this question of enough sessions. One of the concepts of the EAP, theoretically anyway, is that it's not originally it wasn't really intended to be like its own behavioral health network. It was intended to be like a temporary, it's intended to help people through acute moments of crisis and then get them referred to a more stabilized support system, what if that's behavioral health. So one of the questions I would be interested in as far as performance is the satisfaction in the actual handoff from the EAP to the actual plan networks, like how's that going? What is the user experience of that handoff? And that was one of the items that I didn't really hear is part of our assessment of satisfaction. So that's it.
Yeah, those are great questions, Sean. And I think for the last one, as far as that handoff, it is interesting that we have seen a shift, I would say, of EAPs in the last several years, where as we've seen enhanced session models, that we actually see 75 to 80% of people are actually getting their needs met within the 6 to 8 session model. That's like a clinically significant amount. And again, it depends on the person's acuity and what their needs are, right? If somebody has a higher acuity need that is beneficial and supported by ongoing counseling, then oftentimes that EAP provider does act as a bridge, and they help them out of that higher acuity need right at that moment. And then they are meant to be a bridge to getting connected through the medical plan. Canopy does verify if the provider they're recommending to that member is in the medical plan for that seamless, continuity of care. They try to do their best in that type of referral. It just depends on obviously what the member's needs are. But those are two components that are part of the Canopy referral process. So hopefully that's, again, that transition is being done kind of ahead of time, knowing that provider is in the medical plan. We did not ask that question on that last survey, but I think that's a great one for, just kind of hearing about what that transition does look like. And happy to provide more information about the peer support. It is an anonymous text-based online program. People can just drop in, get their needs met, and converse with others. So it's not like there are other peer support programs that are a little bit more, I guess, like in community. And this one is more of an anonymous kind of virtual peer support program, but happy to follow up and get some of those additional details.
Yep, we do have Canopy coming to report to the board in, I believe, 2 months. So
Okay.
We can have them focus, on some of those areas, Sean.
Great. Andrea?
Andy.
So my question kind of piggybacking off Sean. So if members are wanting more, visits with the EAP, is that actually supplementing what we're paying for mental health to the carriers? It's kind of what I'm getting, is that they're not able to maybe get appointments, but my concern is that we're paying 2 things and we're not getting one of them.
We typically see, so EAP, just because there's not any member cost share, oftentimes that is the first, and you can see by the utilization, I think that, so at CL last month, we did our behavioral health, our behavioral health deeper dive. And in that, right, like the Canopy actually has higher utilization than most of the other vendor partner programs. And that's good. That's what we want to see, because I think it is that it's that input place for members that don't have a cost share. They can get their needs met. They are getting in within that shorter period of time. And then once they move to the medical plan, those are claims-based. So you're not paying necessarily a PEPM on the medical plan for direct care services. But I think, Annie, that's a great point too, though, as we're looking at future of like BH360 and some of those pieces that are going to come into play that might have more of a PEPM part of them. It's good to see that Canopy has this higher utilization and that members are using it.
Great, thank you.
Mm-hmm.
Thank you. I don't think I see any more questions right now. have you completed your presentation, my dear?
I have completed, yes, if there's no more questions.
So Dawn, are you looking for a motion to approve? Because I can make a motion to approve.
That's where I was headed. I wanted to make sure that she had completed delivery of the information and that there weren't any more board member questions, and then looking for a motion, yeah?
So this is Siobhan. I'll make a motion to approve the renewal as stated on the screen.
This is Andy. I'll second.
Thank you. Let's go ahead and take a vote then. All in favor, say aye.
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 Any opposed? Any abstentions? And it looks like that vote passes unanimously. Ali, does that meet requirements for this
Yeah,
kind
I
of
was just
vote?
gonna say, just Chicky without, yeah.
And Chiki is not here with us yet.
Yeah.
But we have quorum and that passes. Thank you,
Yeah.
board members. Thank you for the presentation and for being able to answer our questions, as well as that, bringing all that information back so we could understand what we're getting and we're learning from it, so that we can take that learning forward into our next round of renewals. And with that, I will redirect back to Andrew and Emery. Are you ready to present on the round 2 and getting to
We
3.4%? Thank you. Floor
We
is
are
yours.
indeed. Thank you. We'll have a couple of other Mercer folks chiming in throughout as well. But I can get us kicked off here and get the board oriented on the scope and intent of the discussion today. I think that the remainder of the agenda is devoted to this topic, and so we've got plenty of time. However, there's a lot to discuss. As you all know, board members, this is a difficult renewal that we're looking at. The projected costs for 26 are coming in well above the statutory cap, 3.4%. And so a big part of the discussion today will be looking through those optional cost-saving levers that we've included in this deck, and that we provided as some pre-reading as well, to give folks sort of a sneak peek into that discussion and start to think through your own reaction to some of those options. Some of the changes that we've included in that portion of the deck are bigger and some are smaller. And so the goal, once we get to that section, is to really have a discussion with you all and start to hone in on your reaction to those, your preferences around the right balance of the different cost-saving levers, and how a potential use of reserve funds might fit into that strategy to hit 3.4%. And so when we put together that list, we made it intentionally broad. We didn't want it to be too fully baked because, again, this is round 2, and so we're really just trying to facilitate a robust discussion at this point. And so I just say that so that you hear that those are not suggestions or recommendations per se. They truly are options. And there's probably going to be a lot to discuss within each of those options. And so, you know, as I think you all know, no decisions are needed today on the health and welfare benefits. This is round 2. To the extent that board members are feeling adequately prepared in April, at that point, you may feel ready to make decisions for 2026, or if not, that's okay. Those decisions can come in May as well. And then the final rate update would come in the subsequent month. And so at the beginning part of this presentation, we're going to bring forward a slide that you've seen before on PEBB values and how to use that as a decision-making framework, given some of the difficult decisions that the board will be tasked with making this year, given the difficult renewal position. And so we'll spend a little bit of time talking about that. We will spend some time getting you updated on the aggregate and composite cost increase for 2026. Including the relative position of 3.4%, so that you can understand What is that dollar amount that needs to be solved for to comply with the statutory annual cap? Once we've done that, we'll shift gears and spend a good chunk of time talking about those optional cost-saving levers. At that point, we'll spend a little bit of time talking about C-out and sort of just make sure that you're feeling up to date with regards to the work that's happening there that's supporting the renewal. And we'll take a quick look at the timeline as well, so that sort of what's coming down the pike, both in April and then May and June as we look to finalize the rates. So, like I said, we have a lot of time for this presentation, so please do chime in with your thoughts, your reactions, your questions and comments as we're going through. I think we can probably advance, Rose, if you could please, to slide 12. Yes, this one, thank you. And so, similar to when we met last month, there still is a large amount of projected costs that are above the 3.4% statutory cap. And so we wanted to bring forward these 4 sort of primary buckets of cost savings options to continue this discussion on finding the right balance between these levers. While of course, keeping member needs front and center and trying to mitigate impact on members as much as possible. And so in the first bucket, conducting negotiations, this is something that we do in each round of the renewals. And it's really looking at the factors and assumptions that are used by the carriers in their either fully insured premium cost projections or their proposed administrative fees, and understanding, if those are fair assumptions and if there are perhaps elements of their proposals that could be eliminated in an effort to achieve some efficiency and streamline things. The next bucket around improving efficiencies is really sort of one of the preferred levers when it comes to cost saving reductions. And this is one that we explore every year in one fashion or another. And so these are the types of changes that are intended to reduce the total cost of the program, as opposed to benefit changes, which are more of a cost shift to employees. And so, each year, carriers and Mercer will propose different efficiency initiatives and scrutinize those programs, and see how care can be delivered a little bit more efficiently, to not only reduce plan costs, but improve the member experience, improve member health outcomes, and that sort of thing. And so when we get to those optional program changes later on in this deck, we do have some options that fall into this bucket. And so we'll talk through those when we get there. This third bucket is typically the least preferred option for reducing spend. Periodically indexing benefits might make sense in some years, particularly years like 2026 when we're looking at a really difficult renewal position. So especially honing in potentially on those benefits that have a fixed dollar design to them. So like deductibles and copays. And the idea there is that if you don't index those, that benefit gets a little bit richer every year because the underlying unit cost for a given service, primary care visit, or what have you, those underlying costs are increasing, but the member cost share stays static. And so that's sort of the philosophy there. Obviously, whenever we're talking about eroding the richness of the benefit, that has a direct impact on members from an affordability perspective, potentially from an equity perspective, potentially from a health outcomes perspective. If the changes are significant enough to create a hurdle for folks and make them defer care, that's something that I think we're all in agreement is not something that that we want as a potential outcome for some of these decisions. And so I'll say a little bit more on this bucket on the next slide, but the final bucket, the fourth, is use of stabilization funds. And so, whenever the board uses these funds, it's done in a thoughtful and strategic way. I think that you're all aware that there is a dynamic where if those reserves are relied on too heavily, It does create some risks, and it does potentially jeopardize the fund as a whole in terms of its ability to be adequately funded to cover fluctuations in claims and costs. And so last year, the board voted to use stabilization funds strategically to buy down the MOTA and Providence Choice plans so that those plans maintain low-cost plan status. And so as a reminder, that's the low-cost plan status is one where the rates are at least 10% lower than the broad statewide plan. And if the plan can achieve that delta of 10%, it has an impact on the employee contributions for those plans. And so similar to last year, based on how the individual plans are increasing for 2026, we have this problem again. And so when we get to the financial update, we'll get you oriented to sort of the magnitude of that problem, and start to think through what that might mean for decision making for 2026, and potential impact to employees should those plans lose low cost plan status. Okay, any questions or
Sean,
comments so far?
Yeah,
Yes.
Sean, go ahead.
Yeah, I was just I was just gonna say, related to, the third bucket there, benefit changes. I mean, one of the discussions that the board has had over the years is just really that one of the pieces of the reluctance, everything you said, yes, correct, has been part of the board discussion, but also I think what's particularly painful about that section is it doesn't actually solve anything. It doesn't change anything. Like it doesn't fundamentally address the reason why the cost rate is higher than what it should be. It doesn't address anything about the inefficiencies inherent in the system, or it doesn't address something. It doesn't fix something that's broken. So all you're really doing is kind of surviving that particular moment, and then the next year you just can't do it again because you didn't change anything. And that's exactly what basically most health plans in the United States have done the past 50 years, which is why it's a downward spiral. And so if you start relying on that as the button, you'll never stop that button. It'll just keep going because you're not addressing anything fundamental. So I'm not saying that, we can't ever talk about it. I'm just saying that's been ongoing long-term discussion of the board of why it's kind of the last option.
Yeah, thank you, Sean. I think that's well said and good perspective on exactly like you said, why that is the last option. And it's sort of it's kicking the can down the road, and it's also it's a lever to help the board comply with the statutory cap that has been imposed on the board, essentially. But like you said, it's hard to make those changes in a sort of strategic, long-term vision kind of decision-making basis, for all the reasons that you said, where you're not necessarily influencing member behavior when you start to adjust some of those provisions. You're largely shifting cost onto those members. Okay, so let's jump to the next slide. This is one that I know board members, it's probably ringing a bell. We've shown this at a few points over the last couple of months, and I think it might have been in the retreat as well. And in that instance, we applied it as a decision-making framework for the RFP. Now we're bringing it forward and talking about using it as a decision-making framework for the 2026 renewal. And so, like you said, Sean, PEBB historically has really focused on those cost management strategies that don't shift cost, that address inefficiencies or provide steerage or some sort of favorable member impact or favorable member health outcome as a way to sort of reduce the total cost pie. And so to the extent that we discuss benefit changes, two of PEBB's values really need to be sort of front and center, and that's equity and affordability. around any of that discussion around plan design changes. And so how can plan design changes be done as equitably as possible? How can affordability challenges be mitigated? How can cost increase be distributed in sort of a broad and equitable fashion? And so that's not to say that the other core values of PEB can't be considered in that discussion. It's just the two sort of most salient, I think, are equity and affordability. But as it relates to member experience and quality of care, those certainly factor into the discussion as well. With that said, hopefully this is a handy tool as you think through your own reaction and your own perspectives on how best to protect members in this process and participate in the discussion that we'll get to in a little bit and start to tease out, again, what is the least painful route and what is the right balance between all these different levers that the board has available to it for 2026. We're going to shift into financials, but before we do that, I just want to pause and see if there's any comments that anyone wants to make before we take a look at an update on the aggregate and composite costs based on an additional month of data. Okay, I think folks are ready to move forward. So I will hand it over to Emery to provide that update on the financial position and how it relates to the 3.4% statutory cap.
Thanks, Andrew. So we can move on a couple of slides. Actually, I guess 3. So this slide gives you a look at the self-insured and the medical, dental, vision plans in terms of the increases based on round 2 results. Unfortunately, if you do compare this versus last month, the preliminary rate increases have gone up a little bit. The claims came in pretty high. We will update with one more month of claims, but the claims did come in pretty high for essentially for January, which made the premiums go up and made the gap between where PEB currently is and the 3.4% limitation a bit bigger. So statewide is now at 7.6%. Choice did increase to 12.1%, so that is a bit higher. Kaiser came in just under the, at 6.9%. And MODA, their costs did go up as well. There were some definite large claims that were somewhat adjusted for, but in the projections, but additional higher cost claims for MODA. And so their premium rates came in now at 13.1%. That did include a little bit of a reduction on admin fees, but unfortunately, overall, the premium rates did go up a little bit more. We did account for the trend performance guarantees in these rates. So these are offset by that reduction, which helped a little bit, but did not mitigate the entire cost increase. So the dental plans are next. The dental Delta Dental of Oregon did go up a little bit. It's now 3.9%. Kaiser Dental came in at 9.2%. Their actual calculated rate was quite a bit higher, and they did provide a rate concession to bring it down to 9.2%. We took a look at some of the claims and asked Kaiser also for some reasons behind it. And it does look like return to services. I think there were definitely questions, I don't know, the services weren't quite being performed post-COVID, but now they are definitely returning to services. There's definitely return to services. Kaiser's done some things to increase access, and that is showing up in the utilization, and that's resulting in this higher cost increase for Kaiser Dental. Willamette is still at the 7.9, so that's unchanged. And then VSP, if you remember before, is actually minus 0.3%. But again, cost claims did come in a bit higher, and so now it's a 0.3% increase. So overall, it's about $1.5 billion in total for these plans. Any questions before we move on to the next slide? No? Okay. So this next slide talks about ASI Flex Benefit Health Solution and Weight Watchers. So the one change on here is the Weight Watchers. There was a decrease in round two of 12%. So it's about $1.4 million for Weight Watchers. Before it was closer to 1.6, a little bit under 1.6. So there is definitely some reductions as a result here. Andrew, is there anything you want to mention on Weight Watchers before we move on?
No, I think you covered it. There's a couple other changes that I can review a little bit later on in the deck, but the big one was that reduction in the not to exceed cap from the 1.6 million to the 1.37.
Okay. So let's move on to the next slide. Andrew did talk about this, where one of the considerations is the low-cost plan, essentially getting that 10% rate differential between statewide and essentially all the other plans. So historically, Kaiser Deductible, MODA, and Providence Choice have been low-cost plans. As you see on the rates here, Kaiser Deductible's the only plan that's currently coming in as a low-cost plan. That difference to statewide is at minus 11.7. The threshold's 10%. MODA and Providence Choice, it's like 5, minus 5, and minus 6%. Last year, they were not quite at that 10% threshold, if you remember, and the board elected to use reserves to buy down to get MODA and Providence Choice to a 10% differential and thus become a low-cost plan. The low-cost plans, you can see, 1% contributions or 3% for the Oregon University systems. So that is, one consideration to take into account as you're considering the plan design changes. Keeping it consistent across plan design changes, consistent across all of the plans, would not essentially create that delta, increase that delta. You would kind of essentially keep similar gaps between statewide and the MODA and Providence Choice plans. So that's one thing to consider as you're thinking about potential changes to help meet the 3.44% limitation. But that final bullet down below, if you wanted to, is again to use reserves to buy down MODA and Choice rates to get to that 10% differential, it's $31 million in reserves. That number is increasing from what was used last year, but that's something to keep in mind as we move on and you consider your options as we try to get to the 3.4% limitation. Andy.
Oh, so just to kind of clarify, so statewide and Kaiser HMO are the not low-cost plans,
Yes.
correct? Okay.
That's correct.
And then when you said like the 5% employee contribution, so if someone wanted one of those, then that would increase, or they could choose a low-cost plan.
Yes.
Okay, thank you.
Okay. Moving on. So the composite rates. So this is a slide you've seen historically. It shows the composite rates that were essentially voted on by the boards on the left-hand side. The right-hand side is essentially a restatement of the composite rates based on the most recent March census. We just got the March census. Unfortunately, we didn't have time to put it in, so we will get that for you and update the composite rates based on that census next month. But taking a look at the changes over time, the board has been basically at 3.4% for the last essentially 4 years. 22 was 3.3, basically very close to 3.4. 2021, during COVID, the board elected to essentially buy down overall costs and had a 0.8% increase. The 2020 does include the 2% premium tax, which wasn't included before. Otherwise, it would essentially been at the 3 or 4%. But down at the very bottom right now, based on round two, unfortunately, the costs are increasing 9.1%, which is above that 3.4% limitation. And you can see the note down below. It's about 77.6 million, which is about 10 million more than it was last month. So overall, with the claims experience worsening, there's additional 10 million that PEB needs to essentially cut or to reduce in terms of the funding, the overall cost in order to meet that 3.4% limitation from last month. So the number to keep in mind is about $78 million as we move on through the rest of this presentation. Any questions or comments? Okay, next slide, please. And with that, I'll turn it back over to Andrew.
All righty, thank you, Emery. And so before we get into the cost-saving lever options, we wanted to provide this quick view on the administrative fees for Providence and for MODA. These are the fees that are used to cover the expenses related to administering the medical and pharmacy programs. And so one change we did want to call your attention to is a proposed change to tobacco cessation on the MODA side. And so we're proposing removing that from the admin fee and instead treating it as a pass-through claim. And this aligns with our strategy that we've looked at in prior years to move away from a fixed fee and towards a per engaged fee. And so it's sort of an administrative streamlining that we think makes sense. And so this is round two. None of these are final. I guess the way that I like to think about these is to look at the total as opposed to line by line. And you can see in the light blue rows, you can see the proposed increase for 2026, as well as what the increase was for 2025. Any questions on these? Okay, let's move forward and start discussing the optional cost-saving options. And so we wanted to, again, include a really broad list for discussion purposes, and we wanted to start off with the health equity discussion. I see, Emily, you have your hand raised, so I'll pause. Emily, go ahead.
Yeah, sorry, I'm a little slow with my little
No worries.
emojis or whatever. I was just curious, can you remind me for the MODA Health slide, the Spring Health, what that is?
Sure. Rose, could you go back 2 slides, please? Spring Health is a subcontracted vendor that provides essentially a wrap network for behavioral health. And so it provides MODA enrolled members with access to additional behavioral health providers. And they have some really cool features as well around their provider directory, and they provide a lot of additional information on provider demographics. And so it's a little bit easier to achieve congruence to the extent that's important for a member. They can search based on, not only gender, but also other demographics, languages spoken. And so it is a pretty nice addition to the program. And so does that answer your question, Emily?
Yep.
Yeah. Somehow I got muted. I think I'm unmuted. Can folks hear me? Yeah? Okay, I'm seeing some nodding.
Yes.
Okay, thanks.
Yes.
Okay. All right. And so thinking through health equity impact is important for all these cost savings options that we're going to talk through. We do have our health equity work group that is reviewing these changes. For those changes that are a little bit more nuanced, that review is still underway. We have some preliminary comments to make and that sort of thing, and we want to have discussion on that, but know that for some of the more nuanced options, that review is still occurring. For some of the other options that are a little bit more straightforward in terms of cost shifts, the reality from an equity perspective is that they do have an impact on affordability for members. especially members of low-income communities. And so that is a reality that, we just want to make sure that we're naming and talking about and thinking through, how to mitigate impacts so that certain groups aren't disproportionately hit by any cost changes, and how to do it as equitably and broadly as possible. And so we've included a couple examples here in these bullets. So deductibles is one area where potentially those cost increases are spread more broadly amongst the population versus, a copay for like a chronic care visit, for example, on the extreme side is like that really is much more narrowly felt by folks with chronic conditions. Kimberly, I see you have your hand up.
I was just wondering if we know like how many people would be affected. So this would be everyone affected, or is there a subgroup of who would be affected by this?
So it depends on which option we're talking through. And so for many of the options as we go through these slides, we have called out the member impact where we have it. And for others, we don't have it. And so some of them will be broad and some of them will be, so something like increasing the deductible, we would sort of assume that impacts everyone. I guess to the extent that you're a non-utilizer, there's going to be some percentage of folks who aren't hit by that. But we have tried to call out member impact as we're going through to help give you a sense for the volume and sort of how far reaching a given change would be. But yes, great question. Any other questions or comments that anyone wants to make on it? Yes, Emily, I see your hand raised.
Yeah, thank you. I'm just struck by the presentation you provided last month about the disparity in the offering of GLP drugs to communities of color. And so would that be one example of what we would be thinking about in terms of our health equity impact?
So it could potentially be in the terms of like that dynamic could exist within some of these proposed changes, specifically related to GLP-1s. That's not something that's included in this presentation, just because that would be an enhancement that would come with a price tag. And so definitely something for, I think collectively we'd all agree, like that is something we want to continue to look at. And if it's possible, that's an enhancement that makes sense for a lot of reasons. But
Andrew?
Yeah. Yes.
Can I respond to?
Sure. Yeah.
Just on the GLP-1 that we were.
You're
calling
really
out.
quiet for me. I don't know if other people are having trouble.
Can you hear me better now?
Yes. Yeah, better.
Okay.
Yes.
Thank you. The disparity that we were calling out in the previous presentation had to do with the prescribing patterns for GLPs. So, right. So even among patients that have access to coverage for insurance, we know that there is a disparity in terms of who gets prescribed GLP-1s. And so that's the kind of thing we want to continue to keep in mind.
Okay, thank you for that correction. Thanks, Sarah.
Sorry, Andrew.
Oh, you're good. Thank you, Sarah, for jumping in. It just took me a second here to pull up the right screen and unmute myself. Okay. All right, I think if we're ready, we can proceed to this sort of laundry list of options and different ways to reduce spend. And this first one I would categorize as largely about efficiency and decreasing costs of a current program. And specifically what we're talking about here is the health engagement model, or HEM. And so HEM is sort of all about understanding personal health risks and getting folks engaged in activities and behaviors that are going to improve their health status. And so the way that the program works is that employees are, if they want the incentive, they are required to complete a health risk assessment. which is that assessment that helps you understand, your sort of current risk profile and help you be informed on some things that you may or may not be doing that are impacting your health. And completing 2 wellness activities, and those are sort of self-reported activities. And so the employee is attesting to the fact that they have done those 2 wellness activities. And so if employees complete those hoops, they get a couple of incentives. One is a $17.50 payment per month into their paycheck. Taxes are deducted from that, so in reality, it ends up being a little bit less than that for employees. So that's one component of the incentive. The other is a lower deductible on their medical plan. And so if you complete HEM, you will get $100 or $300 for dependent tiers reduced from your medical deductible. And so there have been a couple of assessments on this program over the years in terms of trying to evaluate if it does what it sort of purports to do in terms of reducing risky behaviors and leading to better health outcomes. And the findings for those studies that have been done are not hugely impactful in terms of finding significant results of the program. Which is part of why we're bringing it forward here for discussion as one lever to potentially reduce spend. And so there are 2 ways that we have proposed doing that, options 1 and 2. The first would be around just reducing or eliminating one of the incentive components, but keeping the other. And so doing away with the $17.50 per month payment, but keeping the lower deductible for folks who are completing their required activities. Savings for that are about $11 million per year. The second option would be to eliminate the program altogether. And so at that point, both incentives would go away, the $17.50 and the lower deductible incentive. Anyone who's not completing HEM today, and let's say they have a $350 deductible, under this option, we're proposing they would migrate to the lower deductible option. Which is why you'll see the savings on the right are a little bit less, because we're essentially moving some of those folks from a higher deductible into the lower deductible. That eats into the savings here related to this program. And so this is one of those more nuanced topics where the health equity review is underway. We still welcome that discussion, and I'm sure Christy would have some comments to make, and I know Stephen definitely has some comments to make around this. And I believe this is on the agenda for the PMAC meeting that's occurring later this week. And so, getting their perspective will be really key. But I'll pause there, and Stephen, if there's anything I missed that you want to add, please feel free to do so, or Christy or anyone else. Yes, Siobhan, I see you have your hand up.
Yeah, I just wanted to double check. So if the board made a decision to eliminate the HEM altogether, for folks who want to continue doing the questionnaires that the carriers offer, would that still be part of the package that they could just opt into on their own? For example, Kaiser would still have their health surveys that people could do. I just wanted to double check.
Yeah, it's a great question. I wonder, Stephen, if you have a perspective on that. I don't know if the cost of those assessments is baked into the delivery of this program or not, or if you're not sure, we can always check with the carriers. But I would think that those assessment tools would still be available. Would you agree with that, Stephen, or maybe not?
I would agree. I would think carriers generally do offer a health assessment, and yes, it's required for the HEM program model. But generally speaking, all the carriers that we work with throughout the country generally offer their own version of a health risk assessment. And so I think that would still be available. And we could confirm if there's any cost differential to maintain that, but I would think there's probably not. It would be nominal, if anything.
Thanks.
And maybe I'll just make a comment about from the health equity perspective. While it's intuitive that we would think that people who are lower wage or who are marginalized in some way and experiencing other kinds of marginalization. We would think that they would be the most impacted by changes in financial incentives for participating in well-being activities. And unfortunately, the research literature has shown just the opposite, that regardless of the size and the amount and availability of financial incentives for participating in well-being activities, low-wage people in particular do not participate at the same rates that higher-wage individuals do. And the speculation is that they just don't have the bandwidth. They're oftentimes just putting one foot in front of the other to get through the day. Taking care of multi-generational families at home, may have food insecurity, may have transportation insecurity, many other challenges in their lives that have their focus and attention. So unfortunately, we don't really see that the financial incentives for well-being activities disproportionately affect lower wage people and other marginalized populations. So it's counterintuitive. We would think those who need it the most would benefit the most, but unfortunately, that's not the way it plays out in the real world.
Any other reactions from board members or staff members regarding these options? Yes, Andrea.
So I think I've said this before. This is something that the administrative part for HR is sometimes a burden, only because I know, like, for several of us in the university system, it has us not on the program, even though we've done everything, and we've just given up. And so we don't get the incentives, but kind of, like others, like it wasn't worth all the hassle to try and fix it.
I think Ali, I see your hand up next.
Yeah, thanks, Andrew. Just want to make a general comment that, it's obviously, upsetting to see such a big number and some of these options that are out there on the table. And, just to recap a little bit for the board of actions that you've taken in the last year, as far as sponsoring a legislative concept with the OEB board to recalculate that 3.4% test over a broader period of time. Unfortunately, it didn't make it into the governor's recommended budget, but there was a lot of interest in that. And I could see that coming back, being more successful in a shorter legislative session. And then also the performance guarantees, the 3.4% performance guarantees that brought back penalty dollars that, as Emery mentioned, are factored into this year. And then obviously releasing the medical RFP this summer. I think the board is really active, aggressive, and doing the right things. It's just, it's something that OEB is also facing, 8-9% renewal. It's not exclusive to the boards. It's an industry-wide issue facing double digits right now. And unfortunately, with this annual test, it's really going to put the board to the test. So Emery, you mentioned the data refresh, the claims data, and obviously it made the problem worse this month. And was there one more claims refresh next month?
Yes. Yeah. So we're getting the claims right now. This is a time period that we get the February claims. So we'll definitely incorporate that, take a look and see, and hopefully, I think, in prior years, the rates always have come down. This is not one of those years, unfortunately. But yes, we will refresh it, take a look at it, and hopefully that will provide some relief.
Okay,
but no, I can't pronounce it.
Yeah, thanks.
Greg, I see you have your hand up.
Yeah, I think, the HEM thing when it started, of course, was a debacle, but we got it corrected. And even though it's a little bit, I know that, people really like that few dollars because they feel like they're getting something. And I've looked through some of the other slides and I kind of know what's coming. And I think just to begin with, one of the things we need to do as the board is when and when and where we end up landing. The biggest thing is communication as to why we had to do A or B. You're not getting 1750, but your insurance didn't go up by $150 a month. Those are the things that we need to calculate and make sure that are put out there, so that when it's all said and done, it's the same as I've done many contracts. It's the same as when you do a contract. Yes, we gave the state this, but this is what we got for that, and this is what's going to continue down the road for you in compounding the next 10 to 15, 5 to 10 years. And so the dollars that we saved you, or we may have taken here, we saved here for the next 3 or 4 years, which is going to save you X amount. And I think that's a big thing. And a lot of times we just put out there, hey, this is where it is. But I think when we get to this point and everything's done, we need to make sure that we let them know why we cut or why we did what we did and where we saved them money in the future. So just something to think about.
Yeah, well said. Agree with that. Communication is going to be very important, regardless of where the board decides to land on some of these options. Yes,
And
Don.
Andrew, maybe if I can add, I see that we have a question from a board member, so let's go with that first, and I'll then make a comment.
That's good.
Andrew, this is Christy. I just wanted to add on to what Greg had just shared as well. Yesterday in our Health Equity Committee meeting, we had our initial discussion about this, and exactly what Greg spoke about was a big part of our conversation of communicating, because recognizing, I think, that there are give and takes, and so that members understand where the changes are being made, and that this impact might be relatively small compared to maybe what an alternative impact might be to the membership. And so just wanted to say we've had those initial discussions and are working towards April to provide a more comprehensive health equity review.
Okay. Okay, thank you, Christy. Thanks for those comments. I see Don, you have your hand up.
Maybe we lost Don.
Oh, did we lose Don?
I think we did.
Okay, well, how about Stephen? I'll turn it over to you for those comments you wanted to make, and when Dawn rejoins, we can shift back to her.
So John,
How about
Donna,
now?
you hear me? Okay, go ahead. You go ahead.
Oh, I hear you. Okay.
Can you hear me?
Yes.
Okay, that was weird. I wanted to say thank you to Christy, and also thanks to Dr. Neldner, to Stephen for the insight about who actually benefits proportionately or maybe disproportionately from the HEM, and who doesn't, because of the bandwidth it takes to navigate the challenges of the lower tiers of socioeconomic status, like the note that Emily put in the chat. And I think what I'm doing here is reiterating something that Andrew, you said at the top, which is cost shifting to members is the last resort. What we really want to do with this is encourage our contractors to provide the needed services at a lower cost, maintaining the quality, maintaining the equity, maintaining the health outcomes that are most important for our members to achieve. So that's first, is working with them to focus attention and potentially pressure on efficiencies, I think was the language that Andrew was using, and value. What are we getting for our money? And only at the point at which we think we have maxed out that work do we then move to this consideration of cost shifting and transitioning to ask members to put in more money for what is essentially not more service. And that is the difficulty of the work ahead of us here, and it's what Mercer and the PEB staff are helping us to focus on. How can we essentially elicit greater performance without without asking for more money from our members? So thank you for that work and for helping us to optimize that first step of the work before trying to cut or cost shift. Dr. Neldner, thank you for the grace there.
Thank you. And that's a great lead into the comments that I was intending to make. I want to assure you that a change like eliminating one or both, one or either components of the HEM model won't necessarily impact your well-being strategy going forward. The PMAC and the Worksite Wellness Coordinating Council continue to work on that well-being strategy and tactics to implement it. And we've mentioned this before, and this is well grounded in the research, that the very best of all best practices around health and well-being initiatives is leadership and organizational support. We know that PEB is responsible for delivering benefits, and you're doing all that you can to make available many different programs and services that are there to support the health and well-being of your members. However, we know that from a cultural perspective, you don't have reach into all the agencies and all the departments and all the situations that exist. So some of the efforts that we're doing with PMAC and the council are making an attempt to train the trainer and to get the message out about the benefits that are available. And ultimately, it's helping people recognize that there are resources, but also a culture and leadership that promotes it and lives it and models it. So we really do want to assure the board that you're not the only one that has a stake in the game of employee well-being. And I think the more we can leverage the work that Teresa does with the agencies and their individual wellness plans, the work that PMAC and the council and other groups within the state organization are doing to promote health and well-being, those are very important levers, just as important, if not more important, than any of the benefits or programs that are made available. So this wouldn't, in my opinion at least, impact the future of the well-being strategy. It's a component, but as Andrew said in his introduction of this topic, that the evidence isn't that these incentives are really driving people to be involved in the programs. We know utilization is low. We know that the outcomes in those programs are not stellar. So it's going to take other forms of communication, promotion, and encouragement to get people to take action on their health and well-being. Thanks for the opportunity. And open to any questions you may have.
That was useful, sort of different facet, different way to look at the same information. Thank you.
Don, I'm wondering if there are no other comments on this topic, I wonder if this might be a good time to take a break, because the next one will probably involve a lot of discussion. What are your thoughts on that? Or do you want us to proceed?
I was having the same thought, Andrew, and wanting to check in about content here. So yeah, let's go ahead and let's take a break and come back at 11:05, please, and we'll get going. And I'll put that in the chat as well. Enjoy a break, get up and stretch, take some really good deep breaths, and we'll see you back at 11:05. Welcome back, board members. If you could make your presence known, that would be lovely. Cheeky, I see your note. I see Siobhan. If you could speak up, I haven't figured out how to see everybody. Greg, I see you.
I'm here.
Oh, Andy's here.
Andy, hi.
Sean is back.
Sean, thank you.
Kimberly's
Emily's
here.
back.
Kimberly and Emily, we're good to go. Thank you. Welcome back. Mercer, back to you.
All righty, thank you, Don. Okay, let's advance to the next slide. And so this is another option for discussion that is largely around driving efficiency and reducing waste in the delivery system, essentially by providing a tool and putting that in members' hands so that they have line of sight into high quality, low cost providers that are in network. And so we've got a number of slides on this topic. There's a lot to talk about. There is a health equity review that is currently in flight on this topic, as well as some clinical evaluation that's being done in CIAO in April. And so I guess before I start talking about the specifics of the program, previously the board had indicated a preference not to look at any additional subcontracted vendors in 2026. Given the upcoming medical and RX RFP with a 1/1/27 go live date for the awarded proposers. However, given the significant dollar amount over 3.4% based on the most recent cost projection, we did think there was value in bringing this forward for a discussion and a reaction from the board, and start to talk about it if this may or may not make sense to integrate into the MODA and Providence health plans in 2026. You can ignore that asterisk at the bottom. We have completed that exercise and sort of vetted this through the Department of Justice to make sure that that this was fair game to introduce in 2026. And so you can, like I said, you can just sort of ignore that. And so let me just spend a couple of minutes talking about what the solution is. Please keep in mind that we are still evaluating this, and we still are going back and forth with MODA and Providence with some questions regarding this. But we wanted to introduce the idea of this potential solution to you sooner rather than later, and sort of get your reaction to it, but then also tell you there's more to come if you are interested. There will be more to come through those clinical analyses and health equity analyses as well. Okay, and so this is a tool that is intended to bring transparency directly to the members around how are the in-network providers performing from a quality and cost perspective. And so the tool, it provides decision support to members who engage with the tool. There's multiple modalities. There's an app that members could engage with. There's a website. There's also a phone concierge line. And essentially the way that the tool works is that a member will engage with the tool in one of those modalities and search for specific provider types. And then the tool will curate a list of high quality, low cost providers within that specialty type for the member that are both close to them and accepting new patients. And so I think it's helpful to think about a member example. And so if I'm the member and I am needing to see a cardiologist, I can go onto the tool, I can search for cardiologist. It will show me my list of high quality options that are close to me. I have the option of making my appointment through the tool, but I don't have to. Just the mere fact that I've conducted that search is enough for Garner behind the scenes to be able to track that and bump that up against my claims. And if, in fact, I did see one of those identified high-quality cardiologists, even if I scheduled it on my own, Garner will make that connection behind the scenes, and they will reimburse me for my out-of-pocket costs associated with that visit, up to the incentive amounts proposed at $1,000 for an individual or $2,000 for a family. And so as a member, I wouldn't need to do anything to initiate that incentive payment. That would all happen behind the scenes with Garner doing the tracking on their end, and then either sending me a paper check, or if I'd signed up for direct deposits, I could have that amount deposited into my bank account. And so Garner has about, I want to say they said they have 75% of all claims across the country that are feeding into their database. They have in the neighborhood of 530 different metrics that inform their algorithm when they're identifying these high quality, low cost providers. And they cast a pretty wide net. They include all specialty types except for emergency care. And so primary care, pediatricians, cardiologists, oncology, behavioral health sort of runs the whole gamut. And so, one consideration, and there's a lot to like unpack with this tool. But Greg, I want to circle back to your comment around member communication and sort of providing transparency in those communications on why certain decisions were made for, the sustainability of the plan and, balancing out-of-pocket costs with contributions and all that good stuff. This would be an opportunity to say, and hey, oh, by the way, we are providing you with this, what is essentially enhancement. We're providing you with a tool that is not only going to lead to, better health outcomes for you, but oh, by the way, we're going to cover your out-of-pocket costs associated with any of these high-quality providers. And so from a communication perspective, it could be a win, but there's still a lot of vetting that needs to happen with this solution. And so I want to be a little bit careful with my comments. Mercer is not in a position to recommend this at this point, but we are doing our analysis to understand the extent in which it's feasible for 2026, given the RFP, the extent that the goals and intent of this program align with PEBB's strategic goals, which they seem to, in terms of steerage to high quality providers and a good member experience and creating good healthcare consumers. But there's more work to be done. And so we've got a couple of other slides that, okay, I'm going to pause there because I said a lot. We can go through the other slides and when we're ready to, but I see, Sean, you have your hand raised, so I will pause. Sean, you can go ahead.
Yeah, so just a couple of comments. First, so basically what you just described and the example that you gave, that is what I would expect a managed plan is, right? So that in my mind, that is the definition of the difference between statewide and choice. That's what we're paying them to do. But I say that every year, so I'm just, leave that as it is. We'll just say that I'm just registering my protest there on that one. But so there's that. That being said, my second comment is that, like, I have seen many presentations such as this. This will save blank and blank amount of money. I guess I just have like a certain amount of skepticism built in at this point, because if we actually captured all of the savings from all the presentations on all of the products such as this over the years, we currently would be operating at a profit. So for whatever that's worth, that's the next thing. So yeah, I'm just stop there. Yeah.
Yeah.
I mean, it's interesting. It's worth looking into. Appreciate the work. I guess the third final comment is, like, we really did take a good swing at centers of excellence, where looking at our own data, like it was our own data that we have direct access to across our entire network. Turns out it's way harder than you think to find the excellent doctors, because it depends on how you define it and what data source you're using, and no one uses the same data and so on. And so we spent a good 2 years on it, and just kind of couldn't make this system work in a broad sense of like finding excellence, paying people to go, and then having contracts with those excellent providers that had a substantial difference in savings, because, you know, the idea being that they would have savings because we're channeling people towards them. So therefore they're cheaper. And that turned out not to be true, because a lot of these providers, especially specialty care providers, are already maxed out. Like their calendar is already full. So they don't need anyone's help filling their books. So there's no incentive for them to lower their price. So it's not clear to me how they, like, why it would be cheaper or how they would save any costs, because we couldn't save costs that way. So those are my 3 comments. That is all. Thanks.
All right, thank you, Sean. Yeah, those are good comments. I think that skepticism around proposed savings is a healthy reaction. We too are still vetting from an actuarial perspective how they arrived at those numbers. I will say that for some of the inputs, they are specific to PEBS, MODA, and Providence plans, which is a good thing. And so looking at the percentage of current members who are already seeing one of these high quality, low cost providers, to sort of try to back into what's the opportunity here to get more folks seeing those providers. And they do take into account the plan design, because one of the questions we had posed was like, well, some of PEB's plans are really rich. Does that sort of like erode the incentive for someone to go through the process and get reimbursed if they're only paying a $10 copay? Like, are they gonna jump through the hoops of doing the search to get reimbursed by $10? You know, so I think those evaluations are still ongoing, and I know that Emery and our actuaries on the OEB side are both doing that analysis, and so I think there's probably more to come on that front. One other reaction I'll make to your third comment, which is sort of an interesting approach, is that Garner is constantly looking at their high quality providers and looking in the claims data to see if they are seeing new patients or not. And so there's some subset of the code that gets submitted that indicates if it's a new patient. And so if they're seeing that a provider doesn't have one of those, you know, every couple of weeks, they are excluded from the search results, which is kind of cool. So I know that that's one of the ways that they sort of ensure availability of these folks, right? Because this tool is only useful to the extent that it informs actual decision making and engagement. And like, are the members going to see these people? If the providers are fully booked, then like there goes that plan, right? And I think they also have some other tools they were telling us about. They have some other third parties that help them do research to provide as a sort of additional data point in that question of, is this provider available or not? I know that, yeah, per your comments on the IWG and the COE, you know, that is something we talked about a little bit internally. So I don't know if Emery, if you have any comments you want to make on that front, or if not, I can just pause and open it up again and see what other questions and comments folks have.
Yeah,
one of the
actually,
things you
Sean,
said,
go ahead.
one of the things you said, actually, just clarification, because maybe I'm, misunderstanding. We're talking about they would be channeling people to Oregon providers, right? Like it's not like flying them to Atlanta or something, right?
Yeah, this is what's it's an overlay, and so it essentially evaluates the existing in-network providers within MODA within Providence.
Okay, all right. Yeah. Okay, so yeah, on some level, they're still going to deal with Oregon prices. So
yeah,
yes, yeah, and they have access to the contracted rates as well, Sean. So it is based on the PEB's contracted rates in this case. But overall, Dr. Choi can step in on some of the quality and how it's channeling to better, more efficient providers. But the efficiency is not just the price of the services, the underlying unit cost. It's also talking about more efficient uses of services. And I think to your point about this is something you would expect. In the RFP, we are kind of writing this sort of thing into the RFP to expect it. And some of the information we have in regard to what Garner's trying to do, they do have some stats on things that we were trying to achieve in the COEs, like conservative treatment before getting surgeries. So they do look for those sorts of things, making sure that you get the PT before you go get the knee replacement and some of those other things, as well as reducing, like the amount of testing, to make it a little bit more efficient, not to overuse those sorts of things, and just better results as well. So I think it does kind of it is overlapping a lot with, I think, a lot of the goals we're trying to achieve with the COEs. It is not necessarily a COE per se, it's an overlay on top of the network, and they're trying to move members to those higher quality providers that are identified, who hopefully have those visits available for the members. And so, and there's also I think the incentive was a big part, right? With the COE, how's the plan design going to be implemented with it? And with this, as Andrew mentioned, and you can see on the slide, there is a HRA that's an addition. So this is actually, an additional benefit to the members, where you get reimbursed for your out-of-pocket costs. The underlying plan design's we're not changing it, although that's a potential option, but we're not changing that. And this is an additional benefit to the members to use the service. And hopefully that will drive the members to actually, go to a website and look up these providers when they need these services, and to hopefully get more efficient, better care. So hopefully that addresses some of your questions, comments, Sean, but let us know if it doesn't.
Thank you.
So I think we can jump to the next slide, still staying on this topic. We've got, I think, 3 or 4 slides on this option. And so I'll try not to be redundant, because I think I made some comments related to many of the points on this slide. Let's see. We do have some questions that we've posed to Moda and Providence and Garner around search capabilities, related to them providing transparency and disclosing certain demographics that would be of interest to the member. And so you can search by gender today, but there's not a lot of additional fields that you can search by if you're trying to identify a congruent provider. We have found out, and they've responded, that there is some of that ability through the concierge line. If you call in, the concierge line can assist you with identifying providers, if you have, specific types of providers that you're looking for. But we're trying to understand that a little bit better, and exactly what is that member experience for that person calling in and having that discussion on the concierge line. I think that they had told us that language search was on the roadmap for the app and the web-based modalities for 2025. And so again, that's something that if you have a language preference, you would need to call into the concierge line. We have a long list of provider congruence, health equity questions that we are going back and forth with the carriers on, and plan to have a deeper discussion in CIAO on April 1st, I think is the date. And so know that work is happening, but I'll pause there and see if any of that additional information has stirred any comments or questions from folks.
Well, oh, Emily sorry. Go ahead, Emily.
Oh, you can go first, Sean, and I'll go after you.
Okay, thank you. Yeah, just on the congruence thing, that's another, I don't know how the concierge would know, because to our knowledge, the data doesn't exist, right? We've asked in various ways. in our DEI discussions about provider, and it's just like a survey inside, like even Providence doesn't know. They ask their own, for example, same with MODA. They ask their providers these demographic questions, and I think the response rate, if I recall, what was it? Something like 20% or something. I mean, they have no idea. They don't know. They don't respond. The providers don't. So how would the concierge know, right? There's some magic database that they have access to that no one else does. So, I mean, I think there's an inherent skepticism there of like, how would they do that? Are they going to like pay some like money or something to the providers to get them to actually answer the question, or some different system or something? I don't know, but we've run into that problem ourselves.
Yeah. Yeah, I suspect that they would not know any more than MODA or Providence would know. So I don't think it would be an enhancement over current. But so it could mean the concierge, like looking at the MODA and Providence provider directories, which we know are not overwhelmingly populated per your comments on folks not really responding to that voluntary survey. But even that base level of information that Providence and MODA have in their directories is not currently available on the app and web modalities for Garner, if that makes sense.
One thing that the concierge would be doing is they would also be calling providers. So I think there might be an opportunity, if they're not doing then, to maybe even ask personally at that time, as they're looking up appointment availability, just to try to get that information, just get it, through that call. But that's definitely one thing that we can just confirm with Garner and make sure things like that are actually happening. But Emily, you have a hand up.
Yeah, thanks. Sorry. I'm like joining you from my little iPhone. So I'm like switching it back and forth. Yes, so this is amazing information, and I'm just trying to intersect it with the healthcare workforce shortage that we have in Oregon. So I'm just going to throw out a hypothetical, totally hypothetical. This is fake. But well, a lot of our union members that live in Eugene, Oregon, where they have closed the hospital down, and the primary care doctors are in great shortage. Some of our members tell me they've been seeing this doctor like their whole entire life, or 30 years or whatever this doctor is done being a doctor, is retiring, is burned out from COVID, a number of things, and is not going to be their doctor anymore. And didn't give them a lot of notice that they are not going to be the doctor anymore. Maybe less than 2 months notice that they're not going to be their family doctor anymore. And so then our union member is scrambling to find a brand new doctor who doesn't know them and their health condition, nor their family members. And so then they end up only having the Zoom care option. And so I'm just hoping that is on our radar as we move forward, like the reality of having less primary care docs, not just in Oregon, but across the country, after COVID and all of that. And just, I guess I was going to ask about the language ability to search. And so that's great that's coming. It's not there yet. And I love how there's, location and geography. I'm also reflecting on a completely separate system that's not health, but DMV, our DMV situation in Oregon, and how hard it is for people to get, their license renewed and things like that. So they do rely on this sort of virtual system. And, you know, I'm always surprised when I have to go to the DMV, like I can't go to any of the spots that are where I live or near where I live because of the lack of slots available. So then one year I got in a car and I drove to LeGrand, Oregon from Milwaukee, Oregon, because that was the only place where I could get there was a spot open for me to get my driver's license renewed so that I could drive cross country or, you know, drive to Canada or something and not, you know, driving as a person of color is not safe sometimes. And so you don't want to, you know, even though at that time, and this is an old example, like it was Governor Kate Brown, even though she was putting out notices saying, don't worry, you know, if you get pulled over by a police officer, like you can let them know that, you know, that we don't have the capacity to keep up with all our DMV right now, you know. And I was just like, oh gosh, that's really risky for a Black person, an Asian person. Like, you know, that was when it was 300, close to the time when we're having surge in anti-Asian bias and hate, like over 300%. So anyways, all that to say, like, it would be awesome to have a tool like this, but then practically, are you able to get to a doctor within your geographic area of Eugene or Lane County, you know, and if not, like, so how, you know, how far do they need to go? And would that be an option to go outside of your geographic area to reach the specialty doctor? And then I'll just throw in one more example, because we know colorism and racism exists in our healthcare system. So what if one of our union members who's Black, African American, has you know, dermatology issues like skin condition, and has really, you know, gotten searched and found this amazing, you know, dermatologist who specializes in Black skin. And they don't want to lose that dermatologist, or other Black African American union members and their families want to go to that particular Black African American dermatologist. They want to go to a dermatologist who has more experience with Black skin, you know, instead of white skin. And so anyway, so those are just some hypotheticals.
Yeah, so there's a lot of big issues you're bringing up, Emily. I think yes, it doesn't solve the healthcare issue, right? The access, the total number of providers. You know, we're trying to maybe like ask for plans to help with that, but you know, it's a long-term problem, and the current situation is probably not going to help with, you know, increasing access. I don't think you know, there's yeah, so there, we'll just leave it at that. So, you know, so unfortunately, we're not going to be able to address that. But, you know, when we're talking with trying to maybe access the current networks, Gartner does have standards in terms of time and in time to drive. So, for example, primary care, generally it's like within 30 minutes. If you're in a rural area, it's 45. Some of the higher volume specialists are, it's generally you would have to drive within 45 minutes, or if you're in a rural area, 60 minutes. So those are kind of the standards that they have. Down on that bottom, that 92% accuracy for appointment availability, you know, as Andrew said, they're looking for providers who have availability. So 92% of the time, the provider that they're listing does have availability. So I think, you know, they're trying to make sure that you can go see a provider. It may not be that one, unfortunately, that one specific provider who, you know, African American who knows how to handle, you know, Black skin for, you know, dermatology and has that expertise. But, you know, there is going to be some availability there. Um, there are issues, though. I think, you know, based on the information we got from Garner going up and down the I-5 corridor, generally, I think once you get to like through to Eugene, in terms of access, it looks like there's probably going to be pretty good access. But they did bring up situations. I think it was like a enterologist in like Klamath Falls. And, you know, situations like that, there may only be one or two providers who have that specialty. And if they're not designated as a high quality provider, unfortunately, there isn't access. And, there's just a limitation to a lot of this. And it's an underlying healthcare issue that, you know, with rural areas, unfortunately, sometimes you do have to drive. This is not going to really help in that situation because there's just not the providers out there. But hopefully, in a large number of situations, it will. And we will definitely, some of the questions we will continue to vet in CL and hopefully get some better answers for you in this case, and also for PEB members.
Thank you, Emery.
Okay. I'm just seeing, I see there's a hand. Okay, I think that was from Emily. Okay. So if we want to jump to the next slide, we're still on Garner. This is a simplified graphic of the member experience. And so starting on the top left, the member uses the tool, one of the modalities, they search on a provider type. After that, they go and visit one of those top providers. They pay their out-of-pocket costs, whether that's deductible, copay, coinsurance. Provider then submits those claims to be paid as usual. Garner receives the claims feed, including the member out-of-pocket cost share amount. Garner will then automatically reimburse the member via a health reimbursement account, which would be administered by MODA or by Providence, and funded as if it were a claim. That reimbursement is then made to the member and thus sort of completing their cycle and engagement with Garner. If we jump to the next slide, this is a breakdown of how the estimated savings would work. And so the starting point is that, these high quality, low cost providers are saving the health plan money through less invasive, recommendations, not jumping to more invasive options, all the other factors that Garner looks into when they're trying to identify these high quality providers. And so that's our first row, which is a reduction in claims cost. Garner does have an administrative fee for their services, so you net that out. You also net out the projected HRA funding. Funding for HRAs is notional, meaning that it's only going to be pulled from PEBB's claims account based on actual reimbursements that are made to members. And so after you net out the administrative fee and the projected HRA funding, you can see there's a net savings of about $30 per employee per month for both MODA and Providence. Again, we are still evaluating these numbers, but this should give you sort of a general, at least high level conceptual framework for how the savings are generated through a program like this.
So
we did
Sean, you did.
Oh, go ahead, Emery.
Go. Sean has a question in the chat about the reimbursement and the taxability of that. And please, Andrew, double check me on this. I believe it is not taxable because it is part of the healthcare plan and you're reimbursing essentially out-of-pocket costs. So you're just reducing the amount, essentially refunding the amounts that were paid. And so it's not additional income in this case.
Yeah, I agree. We did post some questions to the carriers in Garner around like, well, what are the top conditions or specialty types that are typically driving savings? And the response we got back was that it's really pretty unique depending on the group. And so they sent us over a couple of examples just so we could get a sense, and the results did vary quite a bit. In some instances, OBGYN was a top savings provider. In others, it was cancer, and some others orthopedics, which makes sense because you think about like elective orthopedic procedures. And so some of those saving types are based on high volume versus high impact. And so it does seem to vary by plan sponsor, by group.
So just to make sure I'm understanding exactly how it works. So is what we're doing really at the end of the day on this program is basically Gartner is peeking into Providence's and Moda's, contracts with providers essentially, and they're paying members to go to the provider with lower reimbursement rates, like lower costs. Is that the idea? Is that where the money savings comes from?
I think it's in part that, but it's also looking at some of the outcome data around invasive procedures or readmissions and some of the other quality metrics that they gather on individual providers. And so they're not just looking at the reimbursement rate via the contract with Moda and Providence, but I do think that factors into their analysis and identifying those providers. Do you agree with that, Emery?
Yeah, and it's it's been described as more efficient. So it's whether it's lower cost, but just better use of resources and better outcomes. It's like the overall efficiency of the providers is being measured, and that is part of how the savings are occurring. So yes, they do have, they can look at the claims information in terms of the dollars allowed charges for that specific providers in those networks, but it's more than just that.
Well, that's what I'm trying to drill into. It's like, what are they literally doing? So are they are they directing the member to other care, such as instead of a hip surgery, they direct them to physical therapy? Like, is it that kind of thing? They're channeling them into lower cost treatments? Or are we
So
just looking at different prices between providers, or both?
yeah, so Garner's not directing the treatment. They're just identifying these providers who are more efficient. So in your case about like the hip issue, they are looking at the providers and how often they have uh, do hip surgery, how often they do PT and other metrics. And Dr. Chuang, I think you had some pretty detailed discussions with them, so you can provide some additional information about that. But it's like essentially the episode of care for these members who have hip issues, and looking at the outcomes and the overall allowed amounts for the payments for that episode, and determining whether who the most efficient providers are. So one of the metrics that they have shown for, like in terms of studies for some other of their clients, is that for people who do need, who potentially could go in for a surgery, these providers end up having fewer surgeries. They do go and do the PT first, and that's one of the metrics that they look at to determine the potential value, and then thus provide savings because you're doing the PT instead of having the surgery. So I guess yes, it's trying to do it. You're trying to get the providers who are doing the things that you're asking them to do in your question.
Yeah, thanks, Emery. I'll just add that the goal here is to, provide it in a digestible way to a typical consumer, factoring those parameters that Emery just highlighted. At the end of the day, it should be a joint clinician and patient conversation, and personalized to what makes sense for the clinical situation and the individual's preference. But the goal is to have that choice available that is more likely to be aligned with efficiency, quality, and high value. Now, that being said, because this is from big data, it is somewhat based on distribution. So for every physician, just because you pick the top performer, it's not a cookie cutter. All the care is going to be one way. It's just that on average, their practice pattern tends to align more with efficient, high value care. But obviously, every case would be individualized. And in the aggregate, just one patient going to that top provider, they could land anywhere on that distribution. But over time, in the composite with enough patients, there should be an accumulative value and cost benefit.
Thank you. I think we're all grappling with the primary question that questions that have been brought up, that we expect the carriers to be doing this work already, So we're already paying for the service, and having Garner be able to do that using the same tools, the same data that the carriers already have, and also the challenges that remain with regard to basic workforce availability and how we are expecting for the payers to figure those problems out and establish network adequacy. I think we're grappling with adding a contractor to do that, even as I come around at the end and say, wait a minute, what's being proposed here is savings associated with this, and the likelihood that it will actually cost us the money that we're looking to find rather than save the money that we're looking to find. The likelihood that it will be more costly than beneficial in that sense, I think is low, even if it's possible that we won't save as much money as is being proposed here. So I think the risk to doing it is low, even though I too am grappling with those expectations that I want to have of the payers, and appreciate the sort of finding the middle ground here, which I think you named as taking some of the learning from this conversation, knowing that these tools are out there, and writing it into the RFP for next round, so that this more refined work of encouraging members to use the options that will serve all of those different needs of quality care, accessible care, culturally responsive care, and low cost. Full quintuple aim we're headed for if we're building in health equity and taking care of providers. Even though this would be adding a contract, I think supporting that set of outcomes in the shorter or medium term with the intention of building it into the bigger picture over time might be useful approach. So thank you for the work that you've done to bring that clarity to us, and address our being disgruntled that we're not already getting those outcomes from our current contracts. Thank you.
The past few years about trying to get more efficient, direct members to the right care. And, I mean, they did bring it to us here. We are reconsidering. We're taking steps, I guess, potentially, if this is accepted, to get to that care. But Andrew, is there anything you want to add?
Yeah, I just wanted to comment on the cost savings sort of dynamic with a solution like this. So there would be a performance guarantee in place guaranteeing a certain amount of savings, so that this program could not be an additional cost for PEBB. So Garner is not proposing to guarantee the entirety of these savings, the 4.3 million, the 11.8 million, but they would guarantee up to their fees. And so they would return that to PEBB if, this program doesn't shake out in the way that we would all hope it would. So there is that, but related to the RFP, there is the risk that, we're writing in a lot of these things into the RFP. So there's a risk that if you want to move forward with this solution, it could be a 1-year solution. And then if, some other vendor has some other proposed solution 1/1/27, that is a risk.
And continuity and relationship building with providers being as valuable an investment as it is for members to make, to do the work of getting in with someone and then getting to know them and having providers who know them. I appreciate the potential risk in having to reshuffle the provider network if we wind up shifting contractors. I do think at this point we're potentially looking at you advise me if I'm missing on this, a fairly well saturated market in those areas, that the majority and maybe even the vast majority of providers in those areas are working with our plans. So access hopefully will be less limited in that way.
Emily, I see you have your hand up.
Yeah, I really appreciate all the work that was put into this, including with the carriers, to bring it here at this time early, so that we can start asking more questions. And I'm just thinking out loud, and I hesitated to bring this up because I don't have all the details in front of me. But two things I wanted to bring up are foreign trained healthcare providers. So I understand that there is legislation right now going through Oregon leg session. And it's about it. Maybe Dawn knows more about it or other people. I've been taking a step back from my former ledge lead duties. So I'm not so plugged in currently to Oregon ledge session, but I know there's a really exciting bill out there because we have a lot of foreign trained health care providers in Oregon, but because of the English language barrier, like they know their native language, they've practiced as a physician, a surgeon, emergency, ER surgeon in their homeland, but not here in US because they can't pass the English exams, but they're also interested in serving their own community. So, so that might be an opportunity to really beef up our healthcare workforce so it's more racially, ethnically, culturally, linguistically aligned with the, and so that might be an opportunity. So I encourage all of us to watch how that evolves. So that's just one thing, because really, and it's a strategy that a lot of states, like when I was at Minnesota Department of Health years ago, we were talking about foreign trained workers and I went to a meeting with 70 Russian physicians and they were all working at McDonald's. What a waste, right? Like, why can't we try to get these foreign trained workers who can speak the languages of the patients and clients, who have been trained to provide healthcare services in their homeland? Why can't we help? So this bill that many have participated in crafting over many years in Oregon, it's very exciting to me. I just heard about it. And I can get the bill number later, and to anyone who's interested. And then the other thing I was going to just flag is people with disabilities and developmental disabilities and invisible disabilities. And I was maybe 2 months ago, I was in a national webinar about this and just how going with the lowest cost that plan for people with disabilities is not a good strategy, because a lot of folks, they have their chronic disability. We know it. And so I'm not going to articulate this well because it's been a while since I was in on that webinar, but I'm going to go look up my notes and then I'll follow up with somebody. But I think we do need to take a little deeper look at people with disabilities, developmental disabilities, invisible disabilities, and how best can we support their health and well-being. Because I guess the status quo, the conclusion at this national conference, this national webinar, is that that's not working for our members with disabilities. So those were just two thoughts.
Thank you, Emily. I think that the questions about how we as a broader society might support a more effective health care workforce to meet the needs of the population is a very big conversation, and our work here overlaps with it a bit, but it's a big and important conversation for us to engage in wherever most appropriate. Thank you, Emily.
Yeah, I agree. Thank you for those comments, Emily. And I'll say, as it relates to your first comment and how it relates to Garner, So to the extent that, and I'm not current on that bill, but to the extent that there are foreign trained healthcare providers who join local networks in Oregon, MODA or Providence, the way that it would work in Garner is that there's a lag time of 18 months for new providers. And so Garner essentially will collect data for 18 months. And up until then, for your first 18 months, whether you're a foreign trained provider delivering services for the first time in the US, or maybe you just graduated from medical school, you're essentially excluded until they have 18 months of data. And then at that point, they feel they have adequate, credible data to assess an individual provider on how they're performing. And so in time, they would make their way into the Garner provider, but there would be a lag. We do have
Thank
a
you.
couple of, related to your second comment, we do have a couple of small things on the dental programs around supporting members with developmental disabilities, which is a carryover from last year. There was a lot of focus on it, and there's a couple little things this year too.
Great. Thank
Andrew,
you so much.
Sorry. Andrew, I'm just looking at the time and wondering if we need to go ahead and move on here.
Yeah, let's do that. Thank you for that discussion. Like I said, for those interested, the CIO, this will be a topic in CIO scheduled for first Tuesday of April, let's say April 1st. Okay, so this is another optional cost savings lever around pharmacy that again is trying to create savings through more efficient delivery of drugs. And so this is an optional change that would require members, whenever they're getting their value or maintenance tier medications, to receive those either through the mail order provider or through what's called a Retail 90 network, which is a narrow brick and mortar network where you can get a 90-day supply similar to mail order supply volume, and still have those drugs covered essentially. So it requires members who are getting value and maintenance drugs to fill those prescriptions through either mail order or through this sort of narrow Retail 90 brick and mortar network. And so there are some savings associated with channeling folks through those two channels. And the specific savings will vary depending on sort of the mix of Retail 90 versus mail order. And so you can see we've called those out on the right. And so for Providence, that's estimated to be between $2.2 and $2.8 million in cost reductions in 2026. I will pause there. We have a similar slide on MODA in the next slide. And okay, so the other comment I'll make before I pause is that we did look at geo access standards for the proposed brick and mortar narrow networks, which are those first three bullets in the center column. And so for members living in urban areas, for example, for those enrolled in Providence, 92% would still meet access standards, which is one of those Retail 90 brick and mortar locations within 2 miles. That access standard grows depending on what type of area you live in. And so in suburban areas, 99% of members would have access within 5 miles. And in rural areas, that number drops down a little bit to about 91% of members having access to the Retail 90 location within 15 miles. Providence is proposing for their Retail 90 network, it would be Walgreens, Costco, and Safeway/Albertsons. If we want to flip to the next slide, MODA is proposing the Array RX Core network as their Retail 90 option. And you can see their access standards based on current zip code sort of distribution in those first three bullets. And you can see access is almost met at nearly 100%. And so that makes me speculate if perhaps the Array RX Core network is not quite as narrow as those handful of brick and mortars that Providence have proposed. But I will pause there and see if Sarah Drake, if I missed anything important, please chime in, or if board members, if you have questions or comments, please go ahead.
Yeah, thanks, Andrew. I think the important distinction, as you mentioned, between the Providence and the MODA, what's been proposed, is the size of the narrow network. So Providence, there's a larger savings because essentially they've contracted for more aggressive rates with these specific pharmacies in exchange for volume. So there's more savings with the Providence proposal, but that means that there's less choice for members, and they would need to choose between mail order, and then as Andrew mentioned, it was Costco, Albertson Safeway, or Walgreens. With the MODA proposal, I believe it's over 90% or near 90% of all the pharmacies in their network are in that core network. So there's much less disruption. But members still would be required to use a pharmacy in the network for 90 days or mail order to continue to get coverage for their 90-day medications. I will say this kind of setup is very common in employer plans. It's a common savings tactic. I think years ago we heard a lot about mandatory mail. A lot of the carriers and the PBMs responded with pushback to mandatory mail. Not everybody likes to use mail order or knows how to use mail order. And so this is seen as a compromise where members can choose if they want to use mail order or if they want to use one of the available brick and mortar options.
And Sarah, is it so this would produce savings for the plan, but also for the member, right? Because it would be 2.5 copays for essentially 3 months supply of their drug.
That's right. They'd get the benefit of more drug for a lower copay than if they were to get 3 30-day supplies. Yep.
There would be some work that would need to occur to think about how best to transition members to mail order. Should you sort of want to proceed with this, make sure that members understand what the financial impact would be if they don't make that switch. And so that would need to be part of the discussion if you all were interested in this one. Hi, Andrea, I see you have your hand up.
So I just thought, I know that with depending where, especially for low income people live, they may not have secure mailboxes. And so I think we really need to consider how they're going to get these meds if they don't get stolen or if just someone else. So just something to bring up that we might need to look at.
Yeah, I think that's a great point, Andrea, and I think it's a reason that this kind of proposal might be a better fit than something like a mandatory mail, because this way people that don't have access to a mailbox, they could choose the brick and mortar option. And I think over 90%, if you go back, it's like 100% in MODA, even in the Providence proposal, I think it's like 92% of people in urban areas would have access within 2 miles to one of the brick and mortar options. But, I do want to be, open about it, right? So it does limit the number of pharmacies. We've heard a lot from independent pharmacies in the state. There's concerns about pharmacies not being part of the network. This would limit the number of pharmacies that would be available for members for their maintenance drugs. But the amount of savings is such, we felt we needed to bring it as a proposal because it is pretty meaningful savings. Sean, I see your hand is up.
Yeah, I mean, yeah, seems worth considering. In some way of thinking about it, $2 million is not that much savings. Like it's kind of modest. So, I mean, we're talking.
Did he freeze?
Sean, I think we lost your audio. Are you back?
Oh, am I back?
Yes, now you are.
Can you hear me now?
Mhm.
Am I back on?
Yes, we can hear you.
Yes, you are, Sean.
Okay. I was just saying probably worth considering. $2 million is in my mind kind of a modest savings. Like I think our problem is a $70 million problem, or maybe 80 by next month. So it could be quite a bit of disruption depending for only saving $2 million. So it's just sort of like disruption versus savings is a question, but I think it's at least worth discussing. But that would be the challenge.
I agree, Sean. And that's this whole balancing act that we are in the position of doing, because Mercer has brought a whole bunch of different options for us to consider and think about cobbling together the greatest savings for the least disruption for the best health outcomes, et cetera. And so this is the menu. We're going to have to put something together at the end that adds up to what we need to find at that point at which the carriers can't find it in the value mechanisms of the negotiation. Yeah. All right. Thank you.
One thing we could likely go back and ask for some information on disruption, how many members would have to switch pharmacies. And that could be something to take into consideration. We could ask for that breakdown from the carriers.
The impact of each of these proposals on the number and a nice understanding of who the members are who are impacted by them. That's probably a foundational piece of information we'd like. And you do have a habit of providing it most of the time. Thank you.
Sure, we can get that. Okay. So if there are no more hands, let's proceed to the next slide, please. Okay, so with this optional change, this would combine the medical and pharmacy deductibles and out-of-pocket maximums. So today, the way the plans are structured for MODA and Providence are to have distinct deductibles for medical and for pharmacy. Same for out-of-pocket maximums. And so this isn't increasing one or the other, it's combining them together. And so today, the medical deductible is $250, $750, and the pharmacy deductible is $50, $150 for the MODA and Providence plans. I'll set Kaiser to the side for now because I don't think that they have a pharmacy deductible in place today. And so again, you take your $250 medical deductible, your $50 pharmacy deductible, you smush them together to a $300 deductible that's going to apply to claims on both sides, medical or pharmacy. This one would not sort of be felt equally across everyone. So depending on utilization patterns, some folks are going to feel it more acutely than others. For example, if there's a member today that has an ongoing medication that they're taking, but they don't really go and see doctors much throughout the year, right? Like they really use their plan primarily for pharmacy. Their deductible is going to go from $50 to $300, big jump. At the other end of the sort of utilization spectrum, let's say there's someone who doesn't really use the pharmacy benefit, but they go to the doctor a couple times a year. Their deductible is jumping from $250 to $300, so much smaller, less acutely felt change for that person. And so I just wanted to call that out as a reality for a change like this. It's not going to be felt equally across all users of the plan.
Hey, Andrew, are we able to get numbers on that so we can gauge how many people it would impact? Like how many people hit the pharmacy deductible now on the plans and how many people hit, I mean, I understand it's a smaller change for the visits, the medical. And I guess the other question that I have on that is, I mean, if someone has chronic conditions, but they're going in regularly, but then they don't have to pay to go in regularly because it's covered as part of the chronic condition, then they might not. I guess what I'm wondering is, are the people with the highest needs, would it not impact them that much? Because the deductible amounts are the same. Like if they have both lots of visits and prescriptions, then because this combined amount is as much, I mean, it's not higher out of pocket combined. Would they not be impacted?
Yeah, I think that's probably right. There is a no member out of pocket feature for chronic care visits specifically. And so those members are sort of protected in that way. But generally speaking, the chronic care members with chronic care needs are using likely both medical and pharmacy more than your average sort of patient or consumer. And so I don't know that they necessarily would sort of bear the brunt of a change like this. But on your question on, what we can mine in the data, I think, Emery, I don't know if you have any comments on if we can identify folks who are really exclusively or primarily pharmacy users versus medical. Is there a way for us to parse that out?
Yeah, we definitely have the data to parse it out, so we can take a look at that, Siobhan, and also just get confirmation from the plans as well. But we can definitely take a look at it and get the information.
Thanks.
Okay, I guess in the interest of time, I am going to proceed, but please jump in with any questions or comments. But if we want to jump to the next slide, we're sort of wading deeper into more of the plan design changes that are sort of knee-jerk reactive, ways to, well, won't call them knee-jerk, but they're not changes that solve the underlying problem, Sean, per your comments. And so this one, for example, looks at what kind of savings could be achieved from adjusting the copays for PCP visits, specialist visits, both in person, and then the next two columns are virtual, and then we've got urgent care over on the right. And so for the statewide plan, this is already based on coinsurance, and so we're not proposing changing the PCP and in-person PCP and specialist visits, because that cost tracks with the underlying unit cost, right? It's not like a fixed plan design feature like a $10 copay. However, for the virtual PCP and virtual specialist, there is an option to align those with the brick and mortar benefit. And so today those are 0 member cost share. And so one option could be to align it to what the brick and mortar corresponding PCP or specialist copay would be. There's a little bit of a delta in these options here between specialist and PCP visits. That's not uncommon, just sort of in recognition of the fact that specialist visits do typically have a larger underlying cost. However, folks who have complex needs are going to be heavier utilizers of the specialist visits, and so it's not necessarily a super straightforward decision to make with regards to like creating that differential. And then on the urgent care, this is a proposed $5 increase for the MODA and Providence plans, and then a larger optional increase on the traditional HMO through Kaiser from $5 to $30. You can see sort of taken all together to give you a sense for what kind of savings all of these would generate. It'd be about $8.4 million. We have included benchmarks sort of where available, and for your peer groups, we're using a state government benchmark and also just sort of a general large plan sponsor benchmark of those employers who have more than 10,000 employees enrolled in the plan. I'll pause there for comments and questions. Yeah, sure.
So I think one of the things over time we've tried to adhere to in principle is when we have to shift costs, you may as well do it in such a way that encourages a little bit of behavior change in the direction that you'd like. So, for example, one wouldn't necessarily, you might think about increasing, if we're talking about increasing copays, you might increase them different between, say, like the traditional Kaiser plan or the statewide plan versus the choice plan or the Kaiser deductible plan, for the purposes of nudging people a little towards those lower cost plans anyway, because by the time all is said and done, a great deal of our savings over time has come from people shifting plans, as simple as that. As opposed to raising the exact same amount on the deductible plan and the traditional plan at the same time. It's sort of like that doesn't do anything except just raise prices. So that's just something to think about. The other thing to think about, similar comment, around virtual care is, do we have information that the virtual visits are in fact cheaper for us as a payer? And if they are, if that were true, which I don't know, but if it were, then you wouldn't want to discourage it by pricing it exactly the same as the office visit, really the brick and mortar visit, right? You want there to be a little difference, so that there's still a little nudge towards the cheaper thing, so, as opposed to just like one blanket increase across the board. So that's just a thought.
In terms of the virtual care visits, I think, originally they were definitely cheaper, but I want to say there's been bills in Oregon. Glenn, please correct me on this if it's not, but there's been bills to kind of make parity on pay for that. So, so that would essentially erode any sort of savings as a result of that, unless you have like a, virtual specific network. Go ahead, Glenn.
Yeah, there has been some legislation about making telehealth, on a more pay parity basis, and then there was also the federal legislation out of COVID that did that for a while too. So that might have had some impact.
So I think it's just a question, like it's kind of a yes or no question. Like, in our experience of paying for stuff, do virtual care specialists cost less? And it's kind of like it either does or it doesn't on average. And if it doesn't matter. If it does, then it's kind of like, well, let's think about it, instead of just like making a straight across increase,
Yeah, and I think those are well said points. There's another complicating factor, which is around the sort of low cost plan issue. And so, to the extent that we make plan designs such that, the managed plans are looking better than the other plans, it might help or hurt the differential when it comes to 10% comparison to statewide. I don't know if I said that in the right way, Emery, but it makes it a little bit, it's just another variable that makes it challenging when we're trying to think about behavior, encouraging good behaviors, and the low cost plan status and the contribution that derives from that is a big sort of behavior lever in terms of getting folks to go here or there. But just wanted to call that out.
Yeah, and also, with PEB has been very successful in like getting people to these low cost plans, the more managed care plans. But that also means that if you only want to make plan changes on statewide and Kaiser traditional, you're going to get less and less, savings as a result because it's a smaller portion of the overall cost. I think it's now under 40% for those two plans, it's maybe closer to 30. So you're not going to get as much margin, savings, bang for your buck if you only make changes there. But that said, you do want to incent people into the lower cost plan. So it is a delicate balance that we have to do here and to get to that low cost plan status as well. So not to, yeah, it's not easy, according enough.
So I just want to be conscious of time. I think, Don, we've got about 6 minutes left. Looking for a little direction. Should we jump maybe to slide 40, which kind of, do you think that's a good place to spend a few minutes? And
Yeah, I was going to ask which of these you think you might be able to do some summary on and where you'd like to spend a little time here. It may be the most useful place to spend a little time there on slide 40 up.
Okay, If you're okay, maybe I can make a couple of comments along the way very quickly just to get folks sort of oriented. So Rose, if you could jump to slide 33, please. So this one is around a medical deductible increase with the corresponding savings in the bottom right. The next slide, we've got a change to the out-of-pocket maximum. A little bit less savings, which is expected because most folks are not hitting those out-of-pocket maximums to date. And so less savings when you adjust those. Next slide shows an option to increase just the pharmacy deductible. Next slide combines increasing the copays for lab and x-ray. In some preliminary discussion, this likely would hit folks with chronic conditions a little bit more heavily, given that they use the lab benefit more often. If we were to parse these out, the x-ray that service is more distributed sort of broadly, but the savings are going to be a small fraction of the 3.6 million there. Next slide, option to increase outpatient surgery copay. Pretty minor potential savings there. On the next slide, adjusting the maximum cost share an emergency room visit copay. If you could jump one more slide, please, Rose. I'm sorry, I know I'm going fast. Maximum cost share is captures things that don't accrue to the out-of-pocket maximum. So think like additional cost to your copay or ER visit copay. Sort of small savings there, as well as adjusting the ER copay. And then finally on the next slide, 39, some Kaiser specific changes, the biggest of which would be to eliminate the traditional HMO plan. Obviously it's a big change. We've noted, how many employees and members are enrolled in that plan and the corresponding cost reduction. So jump to the next slide. This will be a place where I can pause and get folks to react once we've sort of got the total view of all the options that we've gone through in this section. Those top four, we've created that little bracket there just to give you a sense for like, well, what does that do for our $78 million problem? And so taken together, those four reduce it by about 50%. So this would be a good place for me to pause. I think that in the dental and vision and sort of ancillary benefits sections, there's not huge stories to talk about. I think Dawn will be okay if we want to defer those to next month. And so maybe if we want to get comments and questions on this slide and then talk about next steps to sort of round out the presentation, does that sound like a good plan? Okay.
Yep. Kimberly.
Oh my goodness. Wow. Okay. So, a lot of really tough decisions to make, right? This board has not been handed an easy decision to make. And I guess I'm worried, like all of a sudden we're like on speed trying to get to the end here to make our time commitment. And we're talking about some major changes. If we could go back the one slide, so you said there's like 2,100 people that'll be impacted by the 21,000 current members and how many are in the traditional plan? I'm just trying to, like, these are a lot of people that all of us on the board are going to have conversations, right?
Yeah, I wouldn't necessarily recommend that one for some other, the impact there and the disruption would be significant. Yeah, and I see Ali, I see you have, did you have a comment, Ali, you wanted to make on that one?
No, go ahead and let Andrea
and
any board members go first. Thanks.
Oh, I just want to say, kind of like with Kimberly, there's a lot of hard conversations I'd have to have with people, but the main people that I know on that plan are chronic. They have chronic illnesses and chronic health problems. And so I think we could, and it's also, I think, one of the programs that has the most diverse members. So I do think it'd be a lot to consider.
So Andrew, I was just going to add, at the outset of this, the board talked about a balanced approach. And one of the things that wasn't really discussed today is the board does have reserves in the stabilization fund to help offset some of this. but we have talked in the past that when you do use the stabilization fund to offset some of these options, that creates an issue for the next year, but it's something next month's meeting that will bring some of that back into the discussion, looking at that balanced approach. Thanks.
So, PEB has used reserves in essentially last year, right, to meet that 3.4%. That's still an option, but it does kick it down the can down the road a little bit here, because you are again deferring some of these hard decisions to next year. The RFP is coming out, and we're going to try to get savings, some pretty good savings from that, and hopefully that will help. I guess where I'm just going to be a little bit of a pessimist is the healthcare cost, the trend discussion internally at Mercer has not been good. There's definitely pressures happening on costs. Medical supplies come from outside of the US, and if they have tariffs on it, it's going to cost more. You have doctor shortages, and doctors from other countries want to come here and help serve? Are we losing providers? Those sorts of situations are going to impact the overall cost, and just inflation for, a lot of general things. And how's that going to impact some of the potential savings or the underlying trends that are happening? So, we are trying to get savings. I guess, there's a little bit more doubt in my mind about how much they might be willing to provide at this point. So it's just something to keep in mind as we go on, that, unfortunately, we're in a tough situation, and we just, we'll have, I guess, ponder this over the next month or next few days, and we'll have further discussions. But, that is an option, but, it does, we'll have these discussions. We'll come up with a solution we have in the past. So hopefully it'll be one that's good for everyone. But Andy.
So I was just thinking, I think this is a really huge thing, and I think it would be really good for us to start preparing our members now and start communications. So I think that the less disruptive, in a perfect world, it'd be nice to give people a year, but we have to do what we have to do. I have to hear you, Memory, like, we got to cut what we got to cut. But I do think that being open and transparent to our members that, hey, this is bad, might help alleviate than being like, oh, by the way, in 3 months, your insurance is changing. Like, I don't want to do that to anybody.
A good observation, Andy. Thank you. Sean?
Yeah, I just want to point out that, if we were to do all four of the top four, and I know those weren't recommendations yet, I'm just saying for the sake of discussion. If all four of those were done, we still have to find something like $30 million after having done that, 35 or so. So that means if we did every last item under the change bucket here, that still only gets you to like 20, right? So I'm just kind of like throwing that out, just like reality check of like where we're at. Not to undo like what Ollie said, right? It was like, we still have to think about reserves and what's the right balance there, because I think that's definitely part of the discussion. But I'm just trying to be like scale wise what we're talking about.
Yes, that is true. One thing to kind of sorry, Sean, but one thing point out a little bit earlier, we still have to deal with the low cost plan issue, right? And that this doesn't really address that gap. But to buy down would be $31 million on the low cost plan, which I don't know, not giving you a solution right now, but would essentially get you to that point, that missing delta in this case, if you did make all those changes. So, Siobhan.
Yeah, so I just want to make a comment because I'm aware that OEB, and this was said earlier, is also facing similar pressures with really high increases, and we know that the 3.4% cap every year doesn't give us a true sense of what the trend is because it's a hard cap every single year. And I know that we have folks that are working to see if we can get a bill to have a 6-year average around the 3.4%, which would provide some relief because it would pull in the pandemic years. It would provide a truer trend of what we're seeing. Now, we have no idea whether this would pass in the legislature. We do know that my understanding is we have employer support for it on the OEB side through the School Board Association, and we certainly have union support. I can speak to SEIU support for it, and we know that OEA is supporting it on the OEB side, and AFSCME. So, we definitely have support for it. It would be lovely if the state as an employer could also get behind it, although I know that is not something we can have people speak to on this call. But I just wanted to name that was out there too. That wouldn't solve for this $77 million. We would still have a hole. At the same time, it would help. So I just wanted to name that's just another effort that's out there to see what we can do to control healthcare costs and have looking at a truer trend of what we're seeing at PEBB.
Thank you, Siobhan. It's true. This is hard work, and it takes some creativity and some willingness to buckle down to get to the solutions that we're going to need to come to. I'll remind you that we do have a little bit more time here, and we'll talk about this again next month. And there is the opportunity, if board members, if any of you are interested in additional information or dialogue, you're welcome to reach out, and the staff and teams would be happy to engage you in between meetings, as long as it's a limited number of folks, to make sure that you have the information you need to think about this. And then I wanted to bring this conversation to a close for right now. Thank you, Mercer. Thank you, PEBB staff. Some hard questions. Do we have any public comment today?
No public comment.
Thank you. Mercer, did you have any final words you wanted to offer in closing?
I would just reiterate your comment on that. This is, we're halfway through the process and nothing is final. We'll continue the conversation next month. There's still a couple of months to go before we really bump up against any hard deadline around decisions. Would encourage, per your offer, would encourage folks to reach out if additional conversation is needed, and we're happy to help with that.
Thank you, PEBB staff. Anybody else?
I put in the chat, Dawn. We'll let the board know when that bill that Siobhan mentioned drops, and so you can be an active participant if you would like to. Thank you.
Thank you. And then I'll just remind board members, attendees, collaborators, partners, teams, our next meeting in April will be a hybrid option. So those of us who are able to gather in person will be able to do that at the Salem Fairview location. I believe more information about that will be forthcoming. Emily.
Sorry, I'm slow. I just wanted to add that I found the bill number that I was referencing earlier. I put it in the chat with a little descriptor, and I also found a related report on costs of brain, what do they call it? Brain drain or of immigrant. Yeah, so that's in the chat in case anybody wants to look at that more. Thanks.
Thank you for those resources, Emily. That's useful. And thank you for the vibrant dialogue. A lot of hard and good thinking here. Appreciate the values. And I'll look forward to seeing you again next time at your Public Employees Benefits Board meeting in April. Thanks to everybody. Have a great day. This meeting is adjourned.
Thanks, everybody.
Thank you.